or in Iraq or other parts of our region. The other factor that led to this course is that over the years, I've been involved in situations where several people develop an illness of unknown cause. And we have to think through the cause of this illness. And many people teach about these type of illnesses, but they usually focus on viruses, bacteria, chemicals, radiologicals. But this doesn't help us in the ER, right? In the emergency department, does this help us? We are sitting there, a patient shows up with an illness. They don't tell us I'm a chemical patient, I'm a biological patient. They come undifferentiated. And only through proper history and physical exam and proper thinking can we really find out what's going on with the patient. And this is why we decided to create a course that really focuses on the clinical manifestations. Primarily that. You will not see a lot of treatment information. This is more a course to help you remember what could this be. What other things can be causing this illness. Even if they're not likely, but possible. And just the fact that you think about these possibilities, I think is an important thing. The chemicals that we can see in these incidents can be varied. And from Syria, for example, we know that initially we had nerve agents. And then when we had the tragic incident in Ghouta, they decided to, they signed the Geneva Convention, and then there was a ban on destruction of the nerve agents. But then we saw more what? Chlorine being used. So there's a variety. And we even saw sulfur mustard in Syria. Of course, Iraq has many cases of sulfur mustard and other chemicals that we will talk about later on. Now, disasters usually are defined as an act of nature or an act of man, which is of sufficient severity and magnitude to warrant emergency assistance. This is kind of a nice, big definition. But really a disaster at the community level is any incident that overcomes or is beyond your capabilities or capacity to deal with it. And an incident that disrupts your day-to-day activities or normal functioning in your emergency department. There are natural disasters and there are technological disasters. The natural ones are not going to be discussed today, but of course are an important type of disasters. The technological disasters are what we will focus on today, and those are usually either overt or covert. Covert is like what Dr. Hammoudi will see with thallium poisoning, for example. It's a covert incident. Overt is when there's an explosion, for example, and release of chemicals. It could be accidental, like a release of chemicals from an industry, or intentional in an act of terrorism. A cluster is what we're going to talk about today, is a group of unusual aggregations of illness amongst people in a community. These people usually are affected or exposed in the same place or similar place potentially. They have things in common, place, or they have time in common, occupation, and those are usually called a cluster of illness. And those can come to your emergency department, and that's why we are going to go through the differential diagnosis of such patients. CBRNE is a term that replaced the old term in World War II, which was NBC. So CBRNE is chemical, biological, radiological, nuclear, and explosive. Now these are usually military weapons, for example. Some of them are used only for military purposes. Others have dual use. An example of a military CBRNE chemical is chlorine, which is also used in industry. But those are not the only chemicals we have to worry about or agents that we have to worry about. There are toxic industrial chemicals and toxic industrial materials and toxic radiological materials. Those are all over the place. They are around you at hospitals, at industrial sites. And those are the ones that can be also used easily. And if they're intercepted, if the chemical security is not robust around them, or the biosecurity or the radiological security is not robust around them, they can be apprehended by a terrorist and used. This is why today Dr. Andy Nelson is going to talk about that in more details, about how to think about the security of these materials in your environment, in your community. So let's look a little bit at the chemical, biological, and radiological characteristics. And I'm going to actually turn around here so I cannot see that far. If you look at chemicals versus biological versus radiological, the first thing is, can they be disseminated over a wide area? Chemicals can, especially when they are gases, for example. Biological, on the other hand, are difficult to disseminate over a large area. Usually, they try to have these biological bombs, for example, in the past, by dropping them from airplanes and spraying brucella or spraying other type of tularemia. But they don't really work that well, and heat can deactivate them as well, so that's a challenge. And also, how do you store them and to use them in the battlefield? Radiological may or may not affect a large area. A nuclear weapon detonation, for example, can affect a large area. A dirty bomb can affect, a significant area. But a radiological device that you put in a room can only expose people around the device. And the further away you are from the device, the less radiation dose you get. As far as security is concerned, chemicals and biological agents have low security because they are used on a day-to-day basis, and they're available at hospitals, for example, and they're easily manufactured or grown in a lab. So the security of these is low, and I would not say more than that because I think Dr. Nelson will talk more about this. Radiological agents vary. There are some radiological agents that are very secure, like uranium, for example, or plutonium. Some are less secure, like, let's say, technetium, or things you use in nuclear medicine, or things you use in industrial settings. As far as the delayed presentations, so this is important for our course, RIMIC, what can cause a delayed presentation of illness. The chemicals usually are going to cause an acute effect, although there are some that cause delayed presentations. A great example of that is dioxins. Another example of that is methyl mercury, and those can have delayed onset of illness. Okay? The biological agents, yes, can cause delayed illness. There's an incubation period, and then there's an illness. Except if you're thinking about a biological illness due to a toxin, like botulinum toxin or ricin, those may have an earlier onset illness. Radiological agents, by definition, have a delay. Radiation rarely cause very severe or overt acute symptoms, usually delayed. As far as the transmissibility of these agents, chemicals are not transmissible usually. But biological, yes, you can transmit a disease from one person to person, depending on what the agent is. Radiological, you could potentially transfer contamination, but that's not really transmissible. So usually we don't think of radiation as transmissible. Biological agents induce immunity. Chemicals and radiologicals do not. Decontamination is important for chemical and radiological, more for chemical than for radiological. It's more important for chemical events than for radiological events. Biological usually does not require decontamination unless you have, for example, anthrax spores that you're trying to clean up. Finally, treatment. For chemicals and radiologicals, it's primarily supportive care with antidotes or countermeasures. For biologicals, now you're thinking about antimicrobials, antivirals, and then vaccines. So I hope with this in mind today, you will use this information every time you see a cluster to try to differentiate, whether it's chemical, whether it's biological, whether it's radiological, depending on this type of information. And also broaden your mind, because the dose is what determines the poison. Really, everything can be poisonous depending on the dose. So don't just look for the ones that are definitely poisonous. Look at any chemical and assess the situation specifically. Is this situation, one where it's a not toxic chemical, but the dose is high, and therefore it can be explaining the effects? You also must really look at the physical properties. We probably don't do that a lot, but you should look at the pH of a substance. You should look at the boiling temperature or the freezing temperature, the vapor pressure at room temperature, What are the warning properties of this chemical or this radiological agent, for example, which usually is very poor for radiological agents. They don't have warning properties because they don't smell funny, they don't look funny, and certainly they don't glow. Chemical agents, on the other hand, may have an odor or may cause an irritation, but it depends on the chemical and how good these properties are to warn people when they are exposed to them. Also, when you look at biological agents, it's important to understand the incubation period. And is it transmissible from person to person? And then how long are you infectious? And what is the time course of this illness? So having this information in your head, I think, is important. If you can't remember it, you have to look it up when you're facing a situation to be better able to respond to the needs of your patients. Let's talk a little bit about warning properties. So the warning properties, such as, for example, odor, may or may not be sufficient or protective. What is the point of you smelling something when the concentration at which you smell that chemical is lethal? Right? Ideally, you want to be able to detect the smell of a chemical at a concentration that is very far from the lethal dose, right? So that you smell it and run away. The other problem with smell is that some people don't have a good sense of smell for certain chemicals as well. It's a lot of genetic factors involved. And there's something called olfactory fatigue, where the nose stops detecting a specific chemical. A great example is what? Which chemical? Thank you, hydrogen sulfide, which causes this olfactory fatigue. And people would smell it for a short period of time, and then they get reassured that it's not there when the smell goes away, when actually it's still there, it's getting higher and higher, and they're going to die soon. Cyanide gas is thought to have a bitter almond smell, but people cannot smell that. Not every person can detect the bitter almond smell. So those are poor warning properties, for example. I hope you remember to use the agent-host environment tool in your response. Every time you are faced with a disaster or a cluster of illness, stop, pause, and think about what is the agent, who is the host, and what is the environment. This is an old epidemiological tool used in public health for infectious disease outbreaks, where they use it when they're dealing, for example, with a malaria problem in a location. We use it for the chemical and radiological in the following manner. First of all, assess what is the agent. Think about it. Could this be a chemical? Could this be a biological? Could this be radiological? If you don't go through this exercise, you'll miss it. I'm not saying every case it is going to be an exotic radiological event, but at least think about it for a second. Okay? And think agent. Okay, let's see. Could this be a chemical? Could this be a biological? Could this be radiological? And okay, let's say you know what the chemical is or the substance is. What do we know about this substance? Is it, a gas, a solid, a liquid? Is it radioactive material in a solid form? Does it emit gamma rays or beta particles or alpha particles? What is the decay products of this radioactive material? Is this a bacteria or virus? Okay. How much of it are we talking about? Is it a lot, a little bit? Is it potent or not? What is the toxicity? What is the route of exposure that is really bad for this specific substance? The next thing you can go through is the host. Who is the victim? Is this a person who is wearing a mask because it's a military person wearing a gas mask on a battlefield? Or is this a child, a pregnant person? Is this somebody who already has immunosuppression that's been affected by radiation? All of these should go through your mind as you are assessing a situation. And what is the environment of this exposure or this event? Was this at a bus stop, like we saw yesterday in the outbreak investigation workshop? Was this outside or inside of a building? Because inside of a building, theoretically, you don't need as much substance to affect people as if it was outside the building, because outside, it's going to evaporate. What are the environmental conditions? What was the temperature? Sulfur mustard in Iraq and Iran caused more respiratory effects than in Europe because of the environmental temperatures conditions. So you need to analyze all of these factors when you look at the incident. An example of that is Bhopal in India. In Bhopal in India in 1984, what was the agent? Methyl isocyanate. What do we know about methyl isocyanate? It's an irritant. Does it contain cyanide? It contains a cyanide molecule, but it doesn't cause cyanotoxicity. What else do we know about it? We know about it, it's highly water soluble. And what else do we know about it? Amount, large amount. This was a chemical used to make other chemicals, so they stored a lot of it in that, on that site. So large amount, irritant, water soluble. Does it get absorbed into the body? Unlikely. It's more of a irritant without significant absorption. Who is the host? Poor people living in structures that are not very protective and living very close to the actual plant. Not very, nothing else special about them. They're just normal people, families, children, adults, men, women, but probably with poor access to care. Knowing, some of these rural areas in India, they probably have poor access to care. What is the environment? The environment was outdoors, open air environment. However, there was an environmental condition which led to temperature inversion, which led to the methyl isocyanate not evaporating and dissipating in the environment. It kept it kind of a lid on a pot, hugging the ground and affecting more people. So analyzing this event using agent-host environment helps you understand the event better and potentially helps you look for specific injuries based on your assessment. Let's think about Georgia, the Republic of Georgia, where there were two woodworkers, people that collect wood from the forest, in a very remote area in Georgia. These people found these two canisters in Georgia, and the agent here was strontium. It's a radioactive compound, strontium. It emits radiation, gamma rays, and it also emits heat. And it's usually used in these remote areas to generate electricity. They're radiothermal generators that are placed in remote areas where it's hard to get electricity to, and they generate their own electricity. They were left behind by the former Soviet Union, because Georgia used to be a country in the former Soviet Union. They were found by these woodworkers. So who is the host? Two woodworkers, two people, healthy. Nothing else unusual about them, but at least just only two, not 100. What is the environment? The environment was outdoors. They found it. It was a remote area, very cold. And because of this, they wanted to heat themselves, and this was emitting some heat, so they thought this is a heat source. So they carried it on their body and to their tent and slept close to it. So that's the environment. And because it's a radioactive material, when you think about what is the agent, gamma rays are going to expose people at a distance, and that's what happened to them. They developed the radiation injury to their back with the cutaneous effects, as well as the bone marrow suppression. One of them died, the other one survived. So finally, just want to pause a little bit here and have you think about this. How prepared are you for a Cbrn incident? Think about that. Are you prepared? Well, we have some research that shows we're not. For example, Dr. Bashar talked about or Dr. Samih Korkut talked about the large number of volunteers in Turkey for disasters. We did a survey in the US of our volunteers and asked them about their attitudes and comfort level with a variety of disaster scenarios. And clearly, they were much more comfortable responding to a weather-related emergency than they would be for a chemical or biological or radiological. They're more scared of responding to that. And I think that'd be a good project maybe in Turkey if it hasn't been done to assess the volunteers here's perception and comfort level with these events. I did a survey amongst emergency medicine physicians several years ago and asked them about radiation knowledge questions and comfort level, and the results were surprisingly, surprising, because they were uncomfortable and unaware of many of the basic knowledge of radiation injuries. So I think we have a long way to go in this area, and we need to certainly try to train our colleagues in this field, because without knowledge, you cannot have preparedness. You can have all the PPE and all the antidotes and all the ambulances of the world, but if you don't have the knowledge, how are you going to respond, especially when you're a physician, required to assess, analyze, and treat? Now, that may be difficult when you think about the thousands or millions of potential scenarios out there. Thousands of chemicals can show up through your door. Thousands of types of radioactive material or viruses or bacteria. It can be overwhelming. And there's no way you will be able to remember every single chemical or radioactive material. And it's no shame in looking something up and trying to get some more information about something. So finding the right resources is important in your response. But you do want to at least start thinking about what could this be. And you cannot wait too long. These are emergencies. So you must start assessing the situation and getting the appropriate laboratory analysis, but that's going to take time if it's available. Some chemicals or biological agents, have diagnostics that are not always available, and some require several days to result. In the meantime, you must take care of the patient. So you need to look at the clinical picture, and you need to know at least which category it fits under, and then start managing it safely and effectively as you get more information as time goes by. So we recommend using this approach of REMIC, which is really the toxidrome-based approach or syndrome-based approach. And the knowledge that you get today in other training courses helps you enrich your differential diagnosis so that you're able to go through a list and see which one is possible, which one is less likely, and which one is more likely. And the CDC, for example, has published a list of chemical toxidrones, for example. And this is available online for free, and you can look through the list just to help you, define some of these categories. But today, we'll try to hit up some of these categories. Irritant is something we are going to cover. Asphyxiant, maybe less so, but we'll talk about anticholinergic. We'll talk about sedative, opioid, stimulant. We'll talk about corrosive, and then we'll talk about a little bit about radiation exposure. This is not an exhaustive list. There are potentially other syndromes out there, but this is a place to start. And the more important thing is to learn how to think through this process rather than go through every single category. So I hope you'll enjoy the rest of the day, and I think we're going to try to stay on time and hopefully finish maybe an hour or 30 minutes earlier than what is scheduled. This is a CAM website, which is available online for free by the National Library of Medicine. It's also an app. It's a resource to help you put together signs and symptoms into different boxes and guide you towards a potential toxidrome. Thank you. Any questions? And then we are going to take questions today as they come. So Dr. Brent Morgan is a professor of emergency medicine at Emory University and is the vice chair of education. What is the new title? Strategic Initiatives. Vice chair of strategic initiatives at our department and the residency program director for medical toxicology at Emory. Dr. Morgan?
I need module 2. Yes. And this says module 3. Maybe this is still it. Okay, cool. Yeah. All right, so our objectives today, we'll be able to list 2 reasons why the GI system is uniquely susceptible to toxicological insults, and then also be able to name the cause of the largest bioterrorist attack in the history of the United States. And so we're going to be talking about GI clusters, so how different exposures potentially result in a GI illness. You can see the GI tract in the diagram there, starting at the mouth and ending down at the rectum. And the GI tract is uniquely susceptible really for a couple reasons. I mean, one, it's a site of contact, right, where a lot of pathogens or toxins can first come in contact with the body. And then also the amount that's going to come in contact is going to be at the greatest at that time when it's touching the GI tract. It also has rapidly dividing cells, and so toxins that make it so that you can't divide anymore, and we'll talk about some of those, are going to affect there, and then you're going to start seeing the symptoms. And then the effects and symptoms are pretty readily apparent, right? So we're talking about people having abdominal pain, vomiting, or diarrhea. And so clinically, we can see that, right away as soon as those symptoms develop, whereas opposed to the other organ system, the hematopoietic system, that's our bone marrow making cells. It also has rapidly dividing cells. If both of these two systems are having adverse effects from a toxic exposure, you got to wait until you start seeing the problems with the bone marrow. So the cells that are in their blood are still going to be there, and you got to wait for those to naturally decline, and they're not able to replace them. So you're not going to see that. We're going to focus mostly just on the GI tract in this, but obviously there are other organ systems in our gastrointestinal system, including our pancreas, our bile ducts, and our liver. Just a little bit about liver. It also gets exposed to a relatively large concentration of a substance that we ingest because it gets the first pass effect that you absorb those things through your gut, goes right up to the liver. So it's going to get a significant exposure. And the liver is also metabolically active. I mean, a lot of tissues in our body are metabolically active. The liver is by far the most metabolically active. And so when it attempts to metabolize these substances, sometimes it can form a more toxic compound, then that can have adverse effect on the liver itself or throughout the body. So again, we're going to focus mostly on patients that are having abdominal pain, nausea, vomiting, and diarrhea. And you can look into different tables about the color of the vomit and the color of the diarrhea. I'm colorblind, so it doesn't help me, but you can always look those up. And we're basically going to go through a series of cases of real events that occurred and whenever we kind of discuss this and talk about differential. But a broad differential, there's obviously the infectious, and usually that's where most of the money's going to be, right? When you have someone comes into your emergency department or you get a cluster, several people, it's usually going to be some sort of infection. They had food together that was contaminated, and most of the times you're going to be correct in that. And so you're looking at different bacterial infections. There can be ones that produce toxins, such as like staph toxin, and those are going to be more rapidly acting because the toxins there is going to start causing the adverse effects, versus ones that are more infectious, and those can be a little more delayed as far as they're invasive. You ingest them, then they have to invade into your intestines and then start causing the symptoms of the infection. Obviously, a lot of virals out there, like rotavirus, for example. Parasitic, which can be even slower in onset. Radiation can certainly affect the GI system and result in abdominal pain, vomiting, diarrhea, and so we'll talk further about that. And then we get into some of the toxicants, so things that don't occur naturally, and potentially be man-made, or they're not made by a living organism, I should say. So there are a lot of metals that can have adverse effects on our GI system. Things that enhance serotonin potentially can cause GI symptoms because we have a lot of serotonin activity in our gut. Cholinergics, the big one being like organophosphates and carbamates, besides having other symptoms, can obviously have a predominant amount of GI systems. Things that cause cell death or interfere with your cell's ability to divide by making it stick in mitosis because the microtubular apparatus can't work, can also then affect the GI system. And then just your plain irritants, things that kind of irritate, and that would be like your laxatives, for example, can make you have the diarrhea. And then toxins, so substances that are made by living animals or living organisms, I should say. So obviously there's a variety of plants that if it should not be ingested. If they are ingested, it can cause GI symptoms. English ivy would be a good example of that. Different mushrooms or fungi. There's a lot of mushrooms that just cause GI effects, and that's it. There are other ones that can cause GI effects and then cause problems with your liver, like the Amanita species. And then the marine toxins that we think about, such as ciguatera, brevetoxin, the ones that are from shellfish poisoning. In addition to having some other symptoms, including like neurologic symptoms, they will present with the GIs at first. So a pretty broad differential. If you get more than one patient who were there kind of together at a certain place, who are having problems with their GI system, such as nausea, vomiting, diarrhea, then that's when you need to start reaching out for help to do some epidemiology about what's going on, and its immediate importance. Obviously, the main cause of these events are going to be infectious, and that's when you're going to want to reach out then to your infectious disease colleagues. And then at some point that you may want or an infectious disease officer at your hospital. And then at some point you may need to get your government involved, because they're the ones that have the resources and the capability to really investigate it, to leave the hospital, to go to where the site was, where the inoculation initially occurred, and then try to do the work there and help in identifying what was going on, and then potentially hopefully to limit its spread so other people don't become sick, or identify other people who may be sick, but they're just at home toughing it out, and you may be able to give them proper care. All right, so we're going to run through, again, a few cases here of clusters of GI illnesses. So this one occurred way back in 1984 in Oregon, which is a state in the northwestern part of the United States. And in September, many people started developing an illness, a GI illness with diarrhea, fever, chills, vomiting, abdominal pain, and having blood in their diarrhea. And this was in a rural area. I think the main town there had roughly 12,000 people, I think, as their population. And then by the end of September, there were over 700 people who had developed this infection. And they'd done some lab testing on them and determined that it was a Salmonella species that was causing this infection. So the State Department of Health started an investigation, and they ended up finding out that all the patients had dined at one of 10 local restaurants in the area. The investigation identified this Salmonella species at those restaurants and their salad bars, and they concluded that the outbreak had been due to the food handlers there having poor personal hygiene, that these food handlers also had caught the disease, the infection themselves at some point before most of the people in the community did, and that they didn't use good hand hygiene, and that's what continued to spread the infection. And so they shut down the salad bars and all these restaurants, and then assumed that had taken care of it. I guess kind of reasonable suspicion, but the locals there had other suspects. They didn't believe what the state had told them. And at the time, there was a community that had recently moved in to their rural area of several thousand people. And they were following this guru, or this spiritual leader, and they're called the Rajnes. And you can see here the picture of him in his car driving up, and all of his followers lining the road for him. And then here's the speaker himself. And they were highly suspicious of that this group had something to do it. As I said, they had moved into this community for a few years before that. There was a smaller town in this community called Antelope. And they had essentially, once they took this over, they ran for office in that smaller community. They won the electoral races, and then actually changed the name of the town, after themselves to the Rajnes. And then they were running candidates in this upcoming election that was going to be coming up in November, the beginning of November as well. And they were trying to sort of take over the county, government. Ended up being that in the election that occurred in November, they had a massive turnout of locals, and they actually were pretty strict then as far as who they allowed to vote. You had to prove that you had, residence there, proved you had to be a citizen of the country, and so they end up the followers of the Rajnesh did not win the election, but again that was more in November. A local U.S. congressman from that area was also convinced that there's something going on and that it was that it wasn't just the salad employees or the employees of the restaurant that caused this. And so they actually called on CDC to further investigate and asked U.S. government to try to investigate. However, most of the government officials thought these locals were just being kind of bigots against the Rajnesh and were prejudiced against them as well. And so they didn't give them a lot of concern to their pleas. However, then that following summer, this leader of the Rajnesh, again, the spiritual guru, he actually at the time had been on a 4-year period of public silence and self-imposed isolation while he was doing his thing. And then shortly after he came out, he started talking to his followers and heard that some things had happened while he was in this period of silence, and that some of his followers had in fact been responsible for this outbreak of the salmonella. And so this was actually a little a trial run they were doing to see how many people they could infect. And then they were going to try to do a bigger one in November when the election was to see if they could get even more of the community ill with this from salmonella or some other type of infection, so they wouldn't be able to go and vote. And then their followers wouldn't have the infection, and they'd be able to vote more and get more of their people elected. And so after he announced that his group was responsible, then the authorities came in and they had their own medical clinic, and they actually found vials of the salmonella that were an exact DNA match to the salmonella that people in the community had developed. And what they had actually ordered it, and they had the receipt from a lab in Washington State, the salmonella species, and they continued to kind of grow it there at their clinic. And they had went to the salad bars and sprinkled the salmonella there on the public salad bars, and then people would come and consume it, and that's how they got infected. There were no deaths from this, and which is great, very fortunate. And they ended up doing prosecution against several of the members of the group. The leader claimed he didn't know this was going on, again, that he was in his public silence period, and so he was not charged. And this ended up being the single largest bioterrorist attack in U.S. history. The next cluster that I want to talk about, this would be a patient who presented to the emergency department with nausea, vomiting, having profuse diarrhea, and also happened to having chest pains. She had a past history of having fibromyalgia and back and neck pain. And she had been going to an alternative practitioner, or what we call a naturopath, in the United States. These are people who kind of sometimes do some weird things that's out of the mainstream as far as what most physicians would do. And she was receiving these infusions once a week for her back and her neck pain. Her symptoms started about 1 hour after her last infusion, and once the symptoms started, actually the naturopath of their office told her, well, go to the emergency department and see if they can do for you. Initially, her labs were unremarkable, except for an elevated white count, and then she got admitted for IV hydration and observation, and they were concerned about infection, so they sent cultures on her. A repeat white count that was done several hours later was also even more elevated and had a lot of immature forms on it as well in the differential. But then over the next 72 hours, her laboratory analysis and her condition continued to worsen, where she developed multi-organ failure. You can see that she developed low white count, low platelets, so she's having bone marrow suppression. She developed acute renal failure. She developed rhabdo. She developed a lactic acidosis, and she developed some hepatotoxicity, and then also had a pretty dramatically elevated troponin. Any thoughts on what she could have been receiving? Ricin, okay. It's a good thought. Well, ricin is something that shuts down cell replication, so through ribosomes and elongation factor 2, so that's something that potentially maybe this naturopath was trying to give a little bit of that. Or colchicine, yeah, colchicine would be a great differential here as well. Colchicine affects your microtubular system so that your cells can't divide. That also shuts down cell replication, so you're going to see the GIs and then bone marrow suppression and then multi-organ failure. So on the third hospital day, she developed ARDS, then hypotension, cardiac arrest, and unfortunately died. And then they had gotten the history of what this naturopath was administering. Ended up sending to post-mortem level. It came back at 32 nanograms per cc. And you're right, is that was colchicine that she was receiving in this alternative medic clinic. This was something that was, again, some of the alternative medicine practitioners in our country were using colchicine for different back pain, neck pain, fibromyalgia. It has its anti-inflammatory properties that it has. And then the state of Oregon, then were able to look into this a little bit more, and they identified 2 other people who probably had died also in the intervening months from this therapy. And they looked further into it and found that these alternative practitioners, they were where these deaths were associated, were buying this colchicine from a compounding pharmacy. And those are pharmacies in the United States where they're not highly regulated, they're not big pharmaceutical companies, and you can contract with them to make a medication for you. And sometimes they have problems with infectious outbreaks. They're not as highly regulated, and then also sometimes with concentration issues. And ended up being that they got the vials of the colchicine that were actually being administered in that lot that they had ordered, and find out that they had 8 times the amount of colchicine that they were supposed to have. And we know that colchicine has a very narrow therapeutic range, and so that difference in dose can potentially be lethal. And so because of this event, again, this was in the early 2000s, the FDA had some rulings on this, and so they first made it so that individuals who were making intravenous colchicine had to stop, and then they were not allowed anything they had there with them. They had to stop selling after 180 days, and then after that, all injectable colchicine products had to be FDA approved. So compounding pharmacies were no longer allowed, just to kind of make it up on a whim and send it out, that they're going to have to be approved by the FDA and go into pretty rigorous standards. So this is an important point also as well, that don't assume that when you have an outbreak and you think it could be tox related, that what on the label is correct, right? So you need to really go there and you need to look at the concentration of everything they've been getting, and whether it's even mislabeled, and maybe they're getting something else. And so that's an important part. And do you guys still have IV colchicine available here in Turkey? Okay, so again, the FDA instituted this in the United States 2008. Before that, we could give IV colchicine pretty readily in the hospital if we wanted to for acute gout attack, for example. And then in 2006, this is even before this outbreak occurred, colchicine, has been kind of, was never really FDA approved. It just got sort of grandfathered in because, as I said, it's been used for centuries, and just got kind of accepted as a medication without having to go under rigorous studies to get FDA approval. But 2006, FDA came up with this new process that they call the Unapproved Drug Initiative, so drugs that are out on the market. If a pharmaceutical company wanted to go and do the study to show that it was effective, then they would be giving priority over that medication, and so they'd be the only one then who could distribute it, and then thus they can set their price, Whereas if something's been there and approved for, or been out in the market for a long time, then smaller pharmaceutical companies that makes generics can make the drug themselves as well, and that usually brings the price down. So then in 2009, a drug company in the US then did the studies and published it, and they got FDA approval for the oral colchicine. And then so since that was only got FDA approved, then no one could come and start giving IV colchicine, because this is the only form that has FDA approval. So someone would, if they wanted to make a different form and have an IV, then they'd have to do that study to show it's effective, and then they get FDA approval to have it on the market. So that's since 2009, we don't have IV colchicine as well, which is fine. But then the problem is it went up dramatically in price, like over 2,000%. In the U.S., it used to be pennies as far as a dose, and now it's not outrageous. I think it's like $5 a tablet, but still, it's the amount that it went up was pretty dramatic. So as we said, colchicine it comes from a couple different plants, from the autumn crocus and also from the glory lily. And it's been used for centuries to treat gout and a few other diseases. I know the ancient Greeks in this area used it, the Egyptians used it, so again, it's been used for a long time. And as we said before, the microtubular apparatus, through its mechanism, how it works, and then it makes it so the cells can't divide, and that's why initially we see the GI symptoms, bone marrow suppression, and then eventually multi-organ failure. Also has potential for a lot of other problems. Has a very long half-life, anywhere from 20 to 40 hours. It also, in addition to binding the microtubules, it can interfere with the cytochrome 3A4, and then also likes to bind to P-glycoprotein as well. So other drugs that are inhibitors of 3A4 or that affect the P-glycoprotein, can really wreak havoc with people who are on colchicine and can result in toxicity in them. There's been deaths that have been reported from as little as 5.5 milligrams of it in a cumulative dose, so we know it has a very narrow therapeutic range. And then also older adults, probably people have pre-existing, renal and hepatic disease, aren't going to eliminate it as well, and the levels can build up, and then result in toxicity and death. All right, the next case occurred in the opposite part of the U.S., so sort of in the northeast, most northeastern state in Maine, a town called New Sweden. And here you had a 50-year-old gentleman who attended his church services, and then frequently after church, so have some treats and coffee in the back where people can kind of mingle a little bit. And he went back there and had some snacks and started a cup of coffee. And then minutes later, he started feeling nauseated. Kind of told his wife, hey, I don't feel good. So his wife drove him home, and then as soon as he got home, he started having vomiting and diarrhea. And kind of toughed it out through most of the day, but was just feeling awful. And so that evening, he got brought to his local emergency department. And unbeknownst to him, 11 other people from his church had also shown up to that emergency department with vomiting, diarrhea, and some of them had low blood pressure. So they all got, kind of IV therapy. A few of them seemed to improve and were discharged. But then about 7 of them did not improve that much, and so they decided that we couldn't let these 7 go. The infection control practitioner of the hospital, who was a nurse, contacted a division of the CDC that was there in Maine that had been set up only after 9/11, when the states got kind of money to help with preparedness and some things like that. And so they contacted the CDC Maine, and they talked about the case, and they had sent cultures on everybody, and then the CDC Maine said, all right, well, tomorrow we'll go to the church and see if we can get some of the things they were eating, et cetera, and kind of test them, see if we can figure out what's going on. However, these patients who remained at the hospital, several of them continued to get worse. They needed continued fluid replacement, and actually a few of them started to need to have pressors. 4 of them got admitted to the intensive care unit, and 3 of them were transferred that evening, kind of Sunday night into Monday morning, to a higher level of care at a referral hospital that was about 2 hours away, because again, this is kind of a small community. And then in the early morning hours of a Monday, an elderly patient who was like 78 years old died. And so when word of this occurred, then this infection control practitioner recontacted the CDC Maine and said, hey, we don't know what's going on. People are getting worse. We don't think, my physicians here don't think this is infectious because people aren't responding to normal therapy. They're getting worse. And at that time, then the CDC Maine reached out to a local poison center, kind of trying to broaden their differentials. Like, well, maybe this isn't infectious. That's what we think it is most of the time, right? When 12 people show up, with vomiting and diarrhea. And so they contacted the poison center, and they discussed a differential about what could be going on. Any differentials on this case? Aconite, so aconite would be a good potential, yes. And where to get aconite from? Okay. Any other thoughts? So iron causes like GIs, okay. Diarrhea, hypotension, okay. Okay, so certainly that one's there. Yeah, it's a really aggressive, form of infection, invasive, and one person died of sepsis. Okay, what about other metals? You said iron. Arsenic. Okay, so they this investigation then started going full throttle. Then that next day, they got some clinical samples and had sent them off for analysis. The CDC, the health department went to the church, looked at the baked goods that had been consumed, and the things that were kind of there. They looked okay. They weren't like moldy and looked contaminated, but they sent them. Maybe someone had somehow spiked them. And then a nurse back at the hospital had gotten more history from people and was being really diligent. What did you have? What did you have? And found out that everybody who gotten ill had drank the coffee. And then she reported that then, and that made the chain up to the CDC, and so there was some leftover coffee that was there, and so they got that for analysis as well. Ended up being that it was arsenic on testing. It was in the bitter brew at this church. And so here's kind of a timeline of events that was in their publications. You can see they had 12 people who presented. There actually were 17 total who got symptomatic. 5 of them toughed it out and just stayed home. Maybe they didn't drink as much coffee, they didn't get as bad. And then again, they made this call to the CDC then on that Sunday. And then on Monday, as we said, you had an unfortunate death. And the CDC staff arrived. And after they had talked with their poison center, the differential of arsenic came into there, and they had the antidote for arsenic, the BAL, mobilized and sent to the hospitals. And they decided to appropriately so high in the differential to start treating them for arsenic before they got the laboratory test back. But then the subsequent lab investigation did in fact confirm that arsenic was the culprit here. And then you had to figure out kind of, who did it and how to get there. And then about 5 days after this event, a resident of the town wrote a note and said that he did it, and then he killed himself. And so that, don't really know the local politics exactly why he did this and what was his motive, but it ended up being that it was, a massive arsenic poisoning event. And so arsenic, is a water-soluble powder that produces a colorless, tasteless, odorless solution. It's been used for centuries as a means of poisoning people. And because before, we knew it was very effective, and people who wanted to murder other folks. That's why you'd have tasters. If you were someone high up in the authority that someone might want to kill, they'd let them taste it and see whether they get symptomatic first. But then we developed the ability to test for it then in the early 20th century. It's also a human carcinogen, so it can cause bladder cancer, lung cancer, skin cancers, several different types. And it's also a pharmaceutical. And so what's arsenic used as a pharmaceutical? Yeah, so for acute proteolytic leukemia, and I think it's used also for, yeah. Okay. So it's a multi-organ, multi-cell toxin. Has the ability to injure the cell so that the cell decides to kill itself. It can induce cell apoptosis. It interferes with ATP production through the Krebs cycle, and that's why it's a multi-organ toxin. It can bind to a lot of different sulfur hydro groups, which are involved in a lot of enzymatic processes in our bodies. Again, that can result in multi-organ failure. It can substitute for phosphorus because it has a similar structure. The arsenic, the pentavalent does, and so that can shut down a lot of different reactions. And then it also can block, there are potassium channels, so it's at risk for causing a prolonged QT and causing torsades, and that can be what some of the immediate death is within the first 24 hours can be of a dysrhythmia. So there can be different types of arsenic poisoning, right? We're talking about acute here. There's also can be subacute, and then there can be chronic, where individuals who have it in their low levels and their well water, and then being exposed to it, like in Bangladesh, then can develop all kinds of adverse health effects from that. But with acute, you get a rapid onset of gastrointestinal effects. You get hypovolemia from capillary leak, multi-organ failure, cardiac dysrhythmias, encephalopathy, and again, it can be lethal within in a 24-hour period. Treatment involves fluid resuscitation, supportive care. You want to send testing for it, although you may have to make your clinical decision based on your high index of suspicion before you get that back. Initially, you can just send just collect some urine and send it off. We call that a spot. But arsenic secretion can vary a little bit, throughout the day. Usually, if you're acutely ill and got massive poison like these people did, a spot's probably going to be pretty good. You're going to detect it, but you want to send that first urine off right away, and then start a 24-hour collection of their urine, and then send that off as well. Since it can prolong the QT, you probably want to try to stay away from other medications that can do that, such as a lot of our antiemetics can do that. So you just got to be wary of that. And then again, if you have a significant acute ingestion that you're pretty sure about, because it's either an intentional suicide or it's just high in your differential, then you want to start chelation therapy. And then our chelators that we have for this are British anti-leucides, or BAL, which is in the U.S. That's the only parental form that we have available for arsenic. It's available intramuscularly. It's hard to give Succimer or DMSA if they're having a lot of GIs, right? They're already vomiting and having diarrhea. How much are they going to absorb? So we're pretty much left with BAL. And then once they can tolerate Succimer orally, then we'll switch to that, because it's BAL can have a lot of different side effects. I'm not sure what chelators you guys have here. I don't know if you have DMPS or do you have BAL? Anybody know? So there, in a lot of countries, we'll have Unithiol, also known as a DMPS, and that can be given either IV or oral. So that's a chelator that's available in Europe and several Asian countries. We don't have it in the U.S., and it's a compounding pharmacy makes it.
They have BAL in Turkey because we used it before for a patient in Georgia.
Okay. All right. Now our last GI case that we're going to talk about, again, occurred in last 2 decades ago, right, 2006. He had a 44-year-old male who said his name was Edwin Carter, and I got that in parentheses, and you'll see why. Presented to a hospital in the UK with vomiting, profuse diarrhea, and weakness. And this illness started, a couple days before in the evening of November 1st. He couldn't walk without assistance. and was having a lot of abdominal pain, and so he asked his wife to finally call in an ambulance. So he gets evaluated there at the hospital. He gets initial diagnosis of gastroenteritis. His initial blood test showed essentially normal platelet count. His hemoglobin and his white count were a little bit high. His BUN and creatinine were a little bit high, and thought that, well, he's just kind of hemoconcentrated, a little pre-renal, so he's dehydrated. And he got started on Cipro for presumed gastroenteritis. Then he tells his providers that really his name is Alexander Litvinenko. And he happened to be a former Russian security, a member of the Russian security service, which is what the present name of the KGB is. He had defected to the West about the year 2000. And the day of his illness, he had met with a couple of Russians for lunch. So anyone familiar with this case? Yeah, so I gave it away. Litvinenko, yes. So broad differential now, right? I mean, as toxicologists, we love the Russians. They give us all kinds of new things to think about with carfentanil gases and ricin pellets and now in radiation. So masters. Over the next few days, his blood counts started to fall to abnormal levels, and this obviously brought in a lot of concern as far as what's going on with this. Why is his blood counts getting lower? That he's getting leukopenia, low platelets. And so his wife asked, his attending physician or consultant physicians whether this could have been a result of poisoning. He happened to be a pentathlete, as well in his earlier days, and was still quite athletically vigor. But the attending at that time, told her the symptoms were common, and an infection, that poisoning was, not likely. A new consultant kind of took over the care then after he'd been there for about 10 days, and they continued to try to look for additional causes of what could be going on. They contacted the poison center, poison unit there in the UK, and discussed a potential differential. This Dr. Victoris, this new attending, had thought that all this bone marrow suppression was going on, was kind of familiar to him and patients that he had previously taken care of who were getting intensive chemotherapy for their cancer, and then also getting total body irradiation, prior to having a bone marrow transplant because they had like leukemia or something like that. And so he became really suspicious of that. And then so he talked with his radiology department about you check for radioactive sources of poisoning, and they came up with their Geiger counter and kind of went over everything and didn't get any activity. And then he started losing his hair. And so when he gets his alopecia, then that kind of made them expand their differential a little bit, especially it made them think about thallium, because when we think about a toxin that can cause alopecia, hair loss, then certainly thallium kind of rises up in the differential. But when we think about thallium poisoning, I mean, you do get GIs. Is this going to play? How do I get that to play, Ziad? Do you know? The video? No mouse? Okay. So you do get gastrointestinal, effects. You get alopecia, which he had, but then you also get usually a really painful peripheral neuropathy, which he did not have. You usually get encephalopathy, but he did not have that. And it also does not cause bone marrow suppression, which is what was, really remarkable about this. I mean, his ANC, was below 500, and even, lower. And so it didn't exactly fit, with that. So then they started thinking, well, could he have gotten radioactive, thallium? And, we give radioactive thallium, right, for our cardiac markers, right, when you're getting a thallium test on somebody. But it's just a little bit of radiation. So they're thinking, well, is it possible that somehow they could give him this massive amount of radioactive thallium? And And that's what caused it, because we're not detecting any radiation on him. And so that was kind of in their differential. Yeah. Sure. It's a video that Ziad had found.
Actually, yeah, you play the music. So this is actually, I want to step back.
Sure.
This is a video that was made by Syrian doctors in refugees in Lebanon when there was a family that was poisoned with thallium in cookies.
Oh, I didn't know that.
Died and about 20 people got affected.
Mm.
It's a sad story because the mother who did not get affected was because she did not want to eat. She saved the cookies for her children because of the hardship in Syria. And she survived, and she is not safe.
Wow.
So they made this video on their own to raise awareness about this.
And so they decided to go ahead and start treating him for thallium and give him the thallium chelator Prussian blue. This case, maybe this was some sort of weird thallium isotope that they weren't aware of that could have resulted in the adverse health effects. Even though his thallium level, he had one level that came back just like a little bit high, and then a subsequent level came back that was nothing. They decided to go ahead and say really we didn't have much else at that point to offer him. Then he got transferred to a higher level of care when it became more and more apparent that this was probably some sort of poisoning event. He got placed under armed guard. The investigation got transferred to Scotland Yard's counterterrorism. And then they started looking at taking more samples and then taking it to higher authorities as far as looking for radiation in him. He ended up dying then on November 23rd, and just right before his death, they ended up finding that he was poisoned with polonium, a radioisotope, which we'll talk just a little bit about. And so polonium is a little bit different in that it emits alpha particles. And alpha particles, again, this is intimidating for me talking about radiation when I got one of the world's experts here right beside me, Dr. Kazi, but I'm sure he'll correct me if I'm wrong. And so alpha particles are not really, don't penetrate very well. So like even a piece of paper or your skin can stop alpha particles. And Geiger counters are not set up to detect alpha particles. So they're looking for gamma radiation mostly, and they emit very little gamma radiation. And the thing about polonium, it also is only produced in significant amounts in state-regulated nuclear reactors. So it kind of tells you that it was some sort of a government or state-sanctioned to be able to someone get that polonium and then be able to give a toxic dose to somebody. And so what had happened is that the investigation revealed that it was probably at a restaurant that he went to with these two Russian agents, that they had sprayed the polonium into his tea that he was drinking, and that he consumed it then, and then that internalized it. And so it became internalized, and so that's why he could still get the effects from the radiation because it absorbed into his body, as opposed to, normally it wouldn't be able to penetrate even our skin. You want to play this video too?
Some type of radioactive material, he or she can be exposed to the radiation emitted by this source. However, he or she does not become contaminated. One way to think about exposure is to think about X-rays. When a person has a chest X-ray, he or she is exposed to radiation, but does not become contaminated with radioactive material. A person can reduce his or her exposure to radiation if he or she is shielded in some way from the radiation. For example, if the person is behind a concrete wall, or if the radioactive source is inside of a lead container. In order to become contaminated, radioactive material must get on the skin or clothing or inside of the body. For example, if radioactive material is incorporated into a dirty bomb, a conventional explosive such as dynamite that has been laced with radioactive material, then people could become contaminated when the device is detonated. Radioactive material on the outside of the body is called external contamination. When a person becomes externally contaminated, simply removing the clothing can remove up to 90% of the contamination. Gently washing the skin and the hair can remove most of the remaining contamination. If a person ingests or inhales radioactive material, it can become incorporated in the organs of the body. This is called internal contamination.
This is what happened to him.
When a person is internally contaminated, depending on the type of radioactive material with which they were contaminated, certain medications can be administered to speed up the rate at which the radioactive material is eliminated from the body. Such medications include Prussian blue and DTPA.
So, the aftermath of this, one of the things they were able to find were 3 distinct contamination paths. One was Limvincto, where he would go, he probably still had like some in his mouth and had washed his hands and then, was touching things, was contaminating this with the polonium. And then also these 2 Russian agents. That wherever they had gone, they thought that maybe they didn't know what they were actually carrying. It seemed like what they were was leaking. They think that they actually had tried 2 other times to poison them, but it just didn't. They didn't have the right scenario to do it because they found it in other hotels that they had stayed at, in previous visits, like the month before to the UK. And they found it on the airplane. They found it again in their hotel rooms, the restaurant where the poisoning occurred. And so they're able to link it to these 2 guys, quite readily. And so this became, a public health problem, and they had to look at the people who were taking care of him in the hospital as well, because they were potentially getting exposed, to radiation, and had to do all those assessments. But in general, they thought that no one was going to have a significantly increased risk of adverse health effects, from this. The Kremlin and Russia, denied all accusations that they were involved with this, and then, has refused to do extraditions of other citizens for trials. If there's going to be a trial, it's going to have to be here in Russia, and so nothing really developed from that. Any questions about this case or any of the cases? I think we'll probably stop here then. Okay. Yeah.
Even if it was detected early, would it be treated?
I'll let you answer that.
It's inevitable death, I think.
So I think polonium, there's no treatment for it. There's some mice studies looking at BAL, but the dose he got was lethal. So there was no way. So he had a very super lethal dose of radiation exposure.
The effect of the contamination where the spies went and where he...
So there were 28, so I'll tell you about the healthcare providers. There were about 28 healthcare providers who took care of him using just level D PPE, using standard precautions. And they measured urine samples on them to see if they've internalized any polonium, and they found nothing beyond the usual background levels. So that was good. And whatever levels they found, they were higher a little bit in the janitors, who are basically cleaning the trash can or changing the sheets, and the nurses. The least exposure was on the contamination was on the doctors, because probably they are the least contact with the patient. So basically, they found some levels that were within accepted occupational limits. Nobody's had any issues. There were about 150 or 200 U.S. citizens that happened to be in these areas that ended up being tested in the U.S., and they were fine as well. So.
Yes.
I have 2 questions. First one, the colchicine oral, will this same effect of the IV colchicine?
So it usually it's going to take a larger dose, but yes, it can have the same adverse effects. So the early GIs that you get, from getting too much colchicine, may limit the amount that is absorbed. So it can be a little bit protective, but if you get it IV or IM, you're getting 100% absorption, so it's certainly a more lethal route. But what oral can certainly cause death.
The other question is different. There is a high suspicion of a patient that he may be exposed without any symptoms. Is there any
To radiation? To radiation?
radiation, chemicals, medication, IV, but there is no symptoms at all? Is there any role of emergency department or toxicologist or labs? Is there any specific investigation that we can do to discover early before the symptoms come?
That's a pretty broad question. It kind of depends a little bit on what you're suspicious, of. And he comes in and he thinks he's just poisoned because he's a Russian agent, and I know they made me just drink this stuff, right? No, I mean, that's.
I had similar case.
How did you handle it?
That we contacted the labs and we did all the investigation that we have in the world because he was a high-level guy. But I'm asking now in the future if this
Yeah, if it's an acute ingestion, you could think in your minds or something I could do to prevent absorption. So I'd go down that pathway. Do we think that charcoal, something like that, could help somebody, like that?
Radiation is easy. The radiation is easy because you can detect it with the Geiger counter.
Unless it's
The trick
alpha
here
emitter.
was that polonium was
Yeah.
a unique alpha emitter, but if he ingested cesium, you can just wave a radioactive. You can wave a Geiger counter on the stomach, and you can. Metals are, metals you can do like a 20. Typically, when people come to us with these complaints, we do a heavy metal 24-hour urine collection for heavy metals.
So there's no magic kind of like test to screen for everything. So you can have certain panels that you wanna order based on symptoms usually. I don't know if NMS has. There's a lab in the U.S. National Medical Services that we send a lot of our tests to, and they have a lot of panels that by cluster of symptoms you can send. I don't know if they have a homicide panel that you're aware of. I wouldn't be surprised if they do. If they don't, they're very, very creative and very good. But again, you're kind of telling them what you want, to test for. So if you have someone who comes in with a sympathomimetic toxidrome, you can kind of tell them that, and then they have a panel of tests to look for, cathinones or bath salts, amphetamines, cocaine.
Yeah, you have to have
Yeah.
some symptoms.
Yeah, you have some symptoms, or where they work, or so because we have a clinic where we see people, and we see a lot of people who are what we call worried well, and they think they're being poisoned with something, and so you kind of talk to them about it and what a differential is, and then you decide whether you want to send something based on what their symptoms are. But if you're thinking about poison with the Russians, I mean that's a broad differential.
All right, thank you, Dr. Morgan.
Yeah, great questions.
All right, so let's take a break.
Okay, a bit too high. Lower it a little bit. Okay, so the next cluster we are going to face together is the cluster of skin problems, which is probably the least favorite of emergency physicians. Emergency medicine doctors, they don't like skin problems because we don't know enough about them, and we just want to send them home and have them follow up with dermatology. But I am going to try to go through this with you and see what we can do to look for potential Cbrn exposures that lead to skin problems. This is a real case that we took care of when I was an intern in Atlanta, so this was not my case. This is a patient that came to our ER, but I was there. I happened to be working in the ER as an intern. He was Spanish speaking, and he said he has this hand. This is what happened to his hand. And he was hurting, and literally he came with this hand. He wouldn't tell us, what's going on. He said that we asked him, did you burn your hand with a fire? He said no. Did you burn your hand with electricity? He said no. Did you, you know, crush it with some trauma? He said no. He refused, he denied all of this. We said, did you put your hand in an acid or a base? He said no. Now, he was a janitor at Georgia Tech University. Now, at the time, I was not, you know, sensitized to Cbrn, or I didn't have, you know, but my colleague, Michael Schwartz, who's a toxicology fellow at Emory at the time, he was a very smart man. He was very clinically solid, and he suspected that this could be a radiation injury, because this person works as a janitor at Georgia Tech University where they have radiation sources. So he thought maybe he handled a radiation source, and because of the delayed onset of injury from radiation, you know, forgot that he touched it, and now he has the radiation effects. And he was very astute about that, so he called the FBI, the Federal Bureau of Investigation, Georgia office, and they went to the Georgia Tech University and did a radiation survey looking for potentially the source on the floor or in a trash can. And they could not find it. They could not find anything. But they published it as a case, as how they, you know, investigated this. The patient had to have a finger amputation, like hand ray amputation, and recovered. And it turns out that he actually was lying to us. He was actually an electrical injury. He was stealing copper wires from the rail and got electrocuted. But he did not want to say that because he was stealing it. But I like this case a lot. I've used this case every time I talk about this because it really highlights the importance of maintaining a broad differential and getting a good history, which Michael Schwartz did in this case. He asked the person, where do you work? He knew it was Georgia Tech University. He realized the university, like Georgia Tech, does indeed have radiation sources. And went to the differential of biological, chemical, radiological, and thought about radiological. If you don't do that, the agent-host environment, you will miss things. That's just a tool for us to retrieve information from our brain. And that's what we're gonna do today by looking at the skin together. The skin has the epidermis, the dermis, the hypodermis. The skin is important for us for many reasons. It protects us from multiple factors, toxins, bacteria. It can also keep heat in our body, keep water in our body. And when we lose the skin, we lose all these protective functions. Now, there are burns that affect the integrity of the skin, but there are also rashes that, although may not necessarily cause a significant skin deficit, but they will have skin manifestations, okay? The differential is really broad, guys. It's really broad. It could be an infectious disease, a thermal burn, an electrical burn, a cold-related injury can cause the skin damage, an allergic reaction, so an immunologic process can cause skin damage, or chemicals can do that, and don't forget radiation. And we will go through these different scenarios and appreciate what is common or what is different. Let's think about the biological question a little bit. You know, here we are looking at usually rashes, okay? And we are looking at potential causes for these rashes, okay? If not a rash, sometimes you see maybe a lesion. You can see a lesion, which is kind of a rash, but it's more like isolated or specific. And we have to think about what potential causes for these rashes. You know, bacteria, for example, you know, are definitely an important cause of these rashes and lesions. Plague is a good example. Anthrax is a good example. Tularemia. These three agents, which are category A biological agents of concern, cause skin manifestations. When you think about viruses, of course, many viruses cause rashes. The ones that are concerning, for example, smallpox, viral hemorrhagic fevers, okay? Viral encephalitis type infections, all of these can have some rashes with them. Now, toxins, on the other hand, like ricin and botulinum toxin, do not cause rashes. Toxins are less likely to cause rashes, except, for example, if you're thinking about a botulism case where you have a wound infection from somebody who's injecting drugs or some other type of wound, gets infected with Clostridium botulinum, like you see on the slide, they can create a toxin. Now, poison ivy is an allergic type dermatitis, so we got to talk about that a little bit. That's a good question, good point. So you need to appreciate the shape of this rash. Is it macular, papular, vesicular, ulcers? And also the pattern of spread is very important in infectious rashes. You know, a chemical rash is not gonna spread in a centripetal or centrifugal fashion. Infectious processes will do that, and you have to appreciate that. And patients with a rash from an infectious process or a skin manifestation of a rash of an infectious process usually have some sort of other associated complaints. They're usually in incubation period, of course, that's tricky, where people may or may not be infectious, where people may or may not have any symptoms, and may be several days and may vary from one person to the other. Plus, you have to think about the sick contacts that have been involved as well, so asking history about other people that have a similar rash. These are clues to take you down the biological path. So follow these clues, ask about them in your history, ask about the sick contacts, ask about the recent travel history, what's going on in the world, are there other infections that are ongoing in the world, or epidemic or pandemics? Does the patient have any prodromal symptoms? You know, do they have other symptoms like fever, headache, sore throat, runny nose, myalgias, arthralgias? So when you go through this history and physical exam with the patient, if you find these, then you ought to be thinking more of a biological cause for the illness. For example, smallpox. I love smallpox because it has a beautiful type of complex of prodromal effects, incubation period, and rash. The incubation initially is 7 to 19 days, but the average is 10 to 14 days. This is the incubation period. And typically, during the incubation period, patients are not contagious. Okay? Then they develop some non-specific symptoms for 2 to 4 days. That has a very high fever, head and body aches, occasionally vomiting, and they could be infectious in this time, but not as much as when they actually have the rash show up. The rash has an early phase, which is about 4 days. And here you have these small red spots in the mouth that disappear, leading to the rash, these same type of red lesions all over the body. And they actually start on the face and spread on the arms and legs, and then the hand and feet. The important thing about smallpox rash is that it rapidly spreads all over the body. And then when the rash shows up, the fever starts going away. The other thing that's important that you see on this slide is that all the lesions are at the same stage. So remember, this rash spreads rapidly from the mouth, disappears in the mouth, and then the body quickly. And they're all together like a symphony, like an orchestra. This is different than what other infection? Chickenpox. Well done. The second phase, the 10 days phase, is where you have the pustules and scabs. Again, all of these phases are infectious, or contagious, and the contagiousness, that's a good term, the contagious period goes away as your rash scabs off and then goes away. So typically by the end of the second week, after the rash appears, most of the sores have scabbed over and you're no longer contagious. And some pictures, historical pictures of smallpox rashes from the CDC website. 1978, I think, is the last one. And we hope we don't get new ones, but we have to be alert, and we have to differentiate a smallpox rash from the chickenpox rash. You see here, there's no orchestra. The next example I want to talk about is plague. Plague is Yersinia pestis. It's a category A agent of concern. And it's interesting because The rash is a little bit different. It's no real rash. It's not a rash per se. The most common form of plague is bubonic plague, and you can get it by a rodent bite or an infected flea. And the bubonic plague is the most common, and you see those buboes. They call them buboes in that groin area. So if you see something like that, you must recognize it. If you see that, you should look at it and say, okay, looks like plague. This is a bubo. And if you see the fingers with these kind of emboli, this is septicemic plague. The interesting thing about plague is that it's not transmissible from one person to one person except one condition. Which one? Pneumonic plague. Pneumonic plague is transmissible, but bubonic plague is not. You have to be exposed to it from the tick, the flea, the affected flea, or the bite from the rodent. Tularemia, on the other hand, is different because it does not have a person-to-person transmission. Tularemia is due to Francisella tularensis, and this is basically a bacteria, and you get it by handling contaminated animal tissues or fluids, or by the bite of an infected deer fly or mosquito or tick, or with direct contact or ingestion of water, food, or soil. The classic scenario here is a hunter that, for example, killed a deer and was working on getting cutting off the meat and skinning the deer on their own, and they get a little cut in their skin or something, and they get infected. And again, no person-to-person transmission. So taking a history about what they do, not just occupation, also hobbies, may take you down this route. And then when you look at the lesion, though, here, it will be a little bit more challenging than plague. Remember, there are multiple forms. There's intestinal, pneumonic, typhoidal, and the cutaneous lesions. The lesions are tricky because they're not, they're not like a rash, and they're usually ulcerative, typically. So you see here a papule on the left upper corner. On the right corner, you see how it ulcerates. One hint in tularemia is the glandular disease. So it's an ulceroglandular disease. And the gland behind this person's ear on the neck would be a bit more typical and will give you a hint that this is tularemia. But if you don't have this gland, really you're just looking at an ulcer on the body or a papule. Anthrax is another important rash or lesion. This is Bacillus anthracis, and it evolves from a vesicle to a pustule to a necrotic ulcer. And it evolves over several days, over 15 days. It is also associated with surrounding edema and erythema. So when you see that, erythema, edema, with the progression over 2 weeks, you have to think of anthrax. Also, you have to think of anthrax when you do a chest x-ray and you find a widened mediastinum, for example, in somebody who has an infection, because it causes mediastinitis. And potentially cutaneous anthrax will have these necrotic ulcers. And I've pursued this in my career. One time, I had a patient that had this lesion that was still early. It was more like a pimple, kind of pustule. And the reason why I pursued it, not because of the rash, I pursued it because he came in with a respiratory illness, and we scanned his chest. And the CT scan result said that he had a widened mediastinum and some mediastinal lymph node enlargement. I asked him what he did, and he told me he's a farmer. So I got all excited. I said, perfect, I got my first anthrax case, I'm gonna be famous. But I asked the question, farmer, maybe horses, got some exposure to the horse or, cow. This is in the US. But again, it wasn't, so I was wrong. It wasn't anthrax. It was just another cause of mediastinal lymph node enlargement, and that pimple was just a pimple. But you have to be aware of what's in your environment. In Georgia, Republic of Georgia, for example, anthrax is common. So you have to be alert to it depending on your environment. I don't know about Turkey, if you see anthrax cases in Turkey, natural anthrax with cutaneous or pulmonary. So it depends where you are in the world. You do see that? Yeah. We see a lot of anthrax cases. I'm just kidding, but they're actually brought to our attention as brown recluse bites. The brown recluse is a spider in the US It's also potentially around the world too. But the brown recluse is a recluse. Recluse means a shy spider. I don't know why they accuse the spider of running around, biting people. But they come to us and say, I've been bitten by a brown recluse. And again, the brown recluse will cause a lesion similar to the cutaneous anthrax. So that's another part, the similarities to cutaneous anthrax, brown recluse, and also nowadays, methicillin-resistant Staph aureus infections. And the ones we see in Atlanta, they come and tell us, oh, this is a brown recluse bite. Most of these end up being a Staph aureus infection. But they accuse the poor spider. So what I usually say, did you see a spider? If they say they haven't seen a spider, I say, okay, Staph aureus. Well, I mean, they're not, I mean, they cause bites, but not as common as you see these Staph aureus infections. So it's, it's difficult to differentiate, whether it's a spider bite or it's anthrax, etc. But this one is actually an anthrax because you see the necrotic ulcer and you see the redness and erythema and swelling around it. This is more typical of anthrax than a brown recluse spider bite. But again, the differential here is really broad. This is not meant for you to read it, but just want to show you how broad the differential of these type of lesions is. So moving away from the biological area, let's think about other causes of more severe skin damage, that basically tissue loss, what we call a burn. The burn, again, could be thermal, could be electrical, right? Could be radiological, it could be allergic, it could be cold-related. All of these can cause tissue loss and a burn. The burn usually is assessed in terms of its depth and its size. The depth is important because the deeper the burn, the more vital structures are lost in the dermis, epidermis, dermis to the hypodermis. And the deeper you get and you lose more of your hypodermis, you lose your stem cells that are supposed to come back and heal the burn wound. And that means a deep burn will not heal and will require a skin graft. Burns that are less deep, more superficial, they can heal with potential for contractures sometimes, but they may be able to heal because they have enough stem cells in there. The size of the burn is important as well because a large burn is going to cause systemic effects from fluid loss, heat loss, risk of infection, and even systemic effects on the lungs, on the kidneys, and protein wasting that can happen from these large burns, let's say 20% body surface area and above. Finally, the burn depth will also affect whether the burn is going to be insensate, where you lose sensation if you lose the sensory nerves, or not. So this is the example of a superficial burn, or first degree. There is no tissue loss, there's tissue inflammation. The cells are angry, that's why it's painful, but the cells are not dead. It's a transient situation, transient injury or stress on the cells. The partial thickness burn, here you have some loss of dermis, and here you have to think about how deep it is. It's very painful because the sensory nerves are injured, but they're still there. It's wet because it's got all the cell content is leaking, and it can actually get infected, and it can also produce loss of water and heat. The full thickness burns are usually insensate because you've lost the dermis, and now you're actually deep, and you're gonna actually develop contractures, and you need grafting. The burn itself is pale because it also lost the capillaries. And the best way to detect a full thickness burn is to look carefully at the erythema. If it's red, it's not full thickness. If it's pale, it's full thickness. If you get a probe and you touch it, if they don't feel it, it's a full thickness burn. Why it's important to differentiate that again? Because of the prognosis. A full thickness burn is going to require a graft. Now the electrical exposure can cause burns as well. Remember that. And those burns though are interesting because, for example, the electrical current can produce heat. The heat can cause the thermal burn. But then deep, you also have the electrical current causing deep tissue damage that is not visible to the outside. This is a guy we had in Alabama when I was in UAB in Birmingham. This man has thermal burns and has electrical burns. You see, you see the current on his chest. This is the, one of the wounds of the electrical burn. And what on his back is a thermal burn because his clothes caught fire. Okay? And here you have more issues to deal with because you have rhabdomyolysis from the muscle damage, kidney failure, compartment syndrome, many other things here beyond just thermal burn issue. So he had all of these together, unfortunately. He was a mechanic and then got electrocuted. Cold weather can cause tissue loss as well. So, you have to ask, were you exposed to a cold environment? Cold and wet environment can lead to these frost bites. Okay, this looks like a burn to me. Could be also a thermal burn would look like this. One is hot liquid, the other one is cold environment. Or chilblains. Chilblains were basically, in some people that have exposure to a wet, cold environment, they can get this reaction. This is a woman there on the right, I think who she had her feet in an ice bath, caused this chilblains. Or frostnip, which is a very minor, early response to exposure to a cold environment that can eventually lead to beyond that, to more deeper burns like a frostbite. So as you see, a burn can be due to all of these. And you have to go through the thought process of what could it be in this specific patient. And you gather clues from the temperature, from the history, and they'll tell you, yes, I spilled some hot liquid on me, or not. And remember our guy Grady, he denied being exposed to electrical current. He denied being exposed to hot liquid. He denied being exposed to chemicals. Is he allergic to something? Unlikely to cause severe manifestations, usually contact dermatitis like this one that Ala mentioned earlier with the poison ivy or poison sumac or poison oak. They cause these typical rashes that are kind of like a linear a little bit with pustular. And yeah, potentially there's a history. Sometimes you don't have a history because people don't remember being exposed to the plant. Or sometimes their pet is exposed to the plant, and then they rub the pet, and they get it on them that way. And these are annoying rashes because they're very pruritic, and they are tough to get rid of. And they're due to this substance called ursochiol, which is in these plants. Don't forget about chemical exposures to metals, like nickel allergy will cause that. Somebody on their belt buckle area will have the allergy, or on their watch. So the location of the rash can give you some clues as well. And allergic rashes can be severe with erythema multiforme or even Stevens-Johnson, and those require burn care. The Stevens-Johnson case would require to be at the burn center. Chemical burns, on the other hand, are going to cause a more burn-like picture, like a thermal burn. And chemical burns can be liquefactive or coagulative. What does that mean? Liquefactive is the chemical digests the tissue as it penetrates deep. So you have deeper and deeper liquefaction of the tissues. An example of that is bases. Bases can do that. Acids, on the other hand, they cause a coagulative burn because as they contact the skin, they cause a coagulum. And the coagulum crusts it off and kind of stops the deep penetration of the liquid. Okay? So acid versus base, coagulative versus liquefactive. Bases are usually deeper in their reach than acids. Now, we think of chemical burns from acids and bases, but that's not the only way you can burn the skin with a chemical. Think about sulfur mustard, think about lewisite, phosgene oxime, particularly sulfur mustard and lewisite. They are not acids or bases. That's not how they cause the damage. And I shared with you yesterday some of the mechanisms that the way they do it. For those of you who did not attend the lecture yesterday, current understanding of leukocyte mechanism of action involves genetic changes, so genetic expression changes from the leukocyte that lead to the unfolding of proteins, and the unfolding of proteins causes the clinical manifestations. And the way you stop that is potentially by preventing the unfolding of the proteins. And there are some countermeasures that are being developed to do that, but an old countermeasure is cold water. This is why when you burn yourself, you put your hand on the cold water, the cold temperature prevents the unfolding of proteins. That's why it works sometimes, limiting the size of a burn when you stick your hand under cold water. So vesicants, again, like sulfur mustard and leukocyte, are going to cause burns, and they're not acid or bases. And the burns from chemicals usually are immediate. Okay, usually they're immediate. The delay in the onset is not typically a chemical burn. Okay? Radiation, on the other hand, is a classic example of a delayed onset burn. So anytime you have a delayed onset burn, think radiation. Most of these chemical burns are local in their effect, although some have systemic complications. Classic example is what? Hydrofluoric acid. Causes a chemical burn, and it causes systemic effects. We also have special cases that we know as toxicologists. A yellow burn. A yellow burn. What causes a yellow burn? Which acid? Nitric acid. So, white phosphorus is a special case. I mean, we have some special chemicals too that we need to know about. This is the guy I had in Grady. This is a sulfuric acid battery. So he, I don't know, like messing around with the battery, splashed him with sulfuric acid. And the reason why I show you this is you see the crust. I don't know if you can see it. See the crust on his forehead? This is the best example I could find of coagulative necrosis. Now that's a close-up. And you see it looks like a thermal burn, right? What's the difference between this and a partial thickness burn? But the history here is important. And of course, you have to look at the eyes, because the eyes can also be affected. And you know, you have to irrigate those eyes when this happens. And this is the guy that he did well. And you know, that burn on his forehead is really managed like a thermal burn. There's nothing else you gotta do. So we don't do much toxicologists with this, you know. You don't need a toxicologist for this case. All you need from me is to like tell you that what is the pH maybe, or what is, they call us to find out what the chemical is, because we have the resources, we can look it up online. This, on the other hand, is a deep liquefactive burn. This is a patient of Dr. Morgan when he was in Charlotte, North Carolina. And you see how the beefy red liquefied burn on her face. Now, on the other hand, hydrofluoric acid, as we said, is going to cause systemic effects. It's not a great acid in terms of the burn itself. I mean, the burn itself is not that bad. But the pain is very severe. Why is there so much pain, Ala? It goes to the bone. It's in the bone. So fluoride ion is small, so it penetrates. The acid is not the main issue with hydrofluoric acid. It's the fluoride and the bone causes hypocalcemia, as you said, and hypomagnesemia. And then you complicate the whole picture with hyperkalemia. And hyperkalemia leads to the cardiac arrest. And of course, hypocalcemia can lead to torsade de pointe. Torsade de pointe or polymorphic ventricular tachycardia. And the management is what? Calcium, 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 depending on the severity of the lesion, of course, and the route. You know, you can pick intradermal, intraarterial, intravenous, depending on the severity. Topical, on the eye, by nebulizer. It really depends on how severe the case is. I've never seen a very severe hydrofluoric acid case. The ones I've seen were more from low concentration hydrofluoric acid in the 10%, 15%. And they typically have pain. And the way I manage those is by either topical, if I can get away with it, but it's hard to get away with it. Most of the time, they keep having pain and they don't feel better. So you have to do the intraarterial calcium gluconate if you have finger burns. it works really well because you insert an arterial line, and you, like you see here earlier, and then you intra-arterial line, and you give calcium gluconate. Don't give calcium chloride intra-arterially, calcium gluconate. And they do really well with that. And the last case I had a few years ago, the guy came twice to the ER, and I felt bad. I was like, okay, I'm done with this. I'm going to just put the arterial line, because we tried to do the topical stuff. We put some topical, we sent him home, he came back the next day, still feeling bad, and we put more topical, taught him how to do it better, and he still came back the next day, and finally we did the intra-arterial. Yes. Yes. And also remember, the hydrofluoric acid may be under the nails, and who wants to pull nails? Do you really want to pull the nails? I pass out if I'm pulling a nail. But you have to, you start wondering, do I need to pull the nails? And so that's why intra-arterial is better. But, we had to admit him to the ICU for this intra-arterial. I tried to put him in the observation area, but they refused. So I had to put him in an ICU for this. I was trying to avoid this whole process, but, eventually that's what I needed to do. No, so that's a great question. So Bara is asking what's the difference between calcium gluconate and calcium chloride. Calcium chloride per ampule gives you three times as much calcium per ampule as calcium gluconate. So if you have crashing patients who you need to give calcium quickly by amp, give chloride. But chloride, if it extravasates, it causes tissue necrosis. So you must have a nice IV, 18-gauge anticubital fossa, probably placed IV, and you can give it, or central line even better. Calcium gluconate you can give intradermally, if it extravasates, it doesn't cause any problems, but it has less calcium per ampule. And calcium gluconate you can give intra-arterially as well, not calcium chloride. Okay? So moving along to the other types of burns, let's think about some of these blister-forming chemicals. The king of that is what? Sulfur mustard, the king of World War I, causing the largest number of injuries in World War I from the chemicals is mustard, more than chlorine. The issue with sulfur mustard, though, is that it has a relationship with ambient temperature. So first of all, if it's hot, like it was in Iran and Iraq war, it can evaporate and cause more pulmonary effects than it did in Europe in World War I, where the temperatures were colder. It also has a freezing point that makes it vulnerable when in low temperature environments. So you cannot really use it through aerial dispersal or aerial bombing in a cold environment. So that's why they added to it other chemicals, such as lewisite. Okay, that's why, for example, the Japanese added lewisite to it when they were using it against China. The good news about it is the mortality is not very high. It's about 5%, 3 to 5%. But the bad news is that patients are going to be sick for a couple of weeks, 2 weeks to 4 weeks, and then that means they're going to be occupying a hospital bed. They're going to be requiring care by a nurse, by a physician, and they will not be able to fight for that period. The toxidrome of a vesicant is, of course, the skin blister, but also the eyes and the lungs. They don't all have to come together. A few years ago, or maybe either 1 year ago or 2 years ago, I got a call from a colleague in the Republic of Georgia. He actually sent me he called me at like 4 in the morning. And I was like, why is he calling me at 4 in the morning? I was awake though, because I was going to a race. I wasn't racing, I'm not that fit. I was going to a medical tent for the race. It was July 4th. We have a race in Atlanta on July 4th. Then he sent me a message on Viber. He says, hey, can you send me some stuff about sulfur mustard? I was like, why is this guy asking me about sulfur mustard at 4 in the morning? So I called him. I was like, what's going on, man? He's like, we have sulfur mustard cases in Tbilisi. I was like, what? It was workers at an airport that saw a leakage of liquid in their kiosk. They have a travel agency kiosk. And I don't know, somebody maybe touched something. We didn't have all the history. But this doctor had in his ER 2 patients, and then the 3rd patient was at another ER. And then, of course, a total of 11 patients presented by the end of this process. They were not injured, but they were concerned, so they came in to be checked out. And those patients that he had this very small pimple on his arm, very small, like less than half a centimeter in diameter. The other guy that was in the other hospital had a bigger lesion, bigger pimple. And it's interesting, they were exposed the day before. So this thing happened on, so July 4th was when he called me at 4 in the morning, which was afternoon in Tbilisi. These guys were exposed the day before on July 3rd. Okay? And they didn't develop symptoms till several hours later. One of them developed some eye burning. Okay, some eye burning, a conjunctivitis. Then he developed the pimple. None of them had respiratory effects. Probably because the amount was very small, and which is reflected in the size of the blister. You know, the larger the blister, the more likely you had a large exposure that's probably causing respiratory effects. Typical symptoms. And I said to him, this is sulfur mustard, classic. And he had found out because actually they found the bottle and it said on it Ipperite. And he's like, what is Ipperite? I said, Ipperite is Ypres in Belgium, the first place where the chemical weapons were used in Belgium. And that's why they call it Ipperite. Anyway, so that's the long story short. They did okay. Those two patients did okay. They had a classic progression of their lesion into the rash. And in a little bit, I'm going to ask Dr. Ala Mohsen and other Iraqi colleagues, Dr. Hammoudi, to talk a little bit about their experience in Iraq. And we have some slides from Dr. Ala Mohsen who shared them with me that will show them. But this is interesting about the mustard, the progression. Now, lewisite was made to cause more immediate effects. Okay, but we don't have a lot of experience in lewisite, unfortunately. Well, fortunately and unfortunately, because it was really never used in a battlefield, but it was more in the lab. When we have a couple of case reports. But look at these blisters, how they are, again, like a thermal burn. You know, this could be a thermal burn. This could be a chemical burn, like an acid or a base. And eventually, as they heal, they have changes in the pigmentation. They can be hypopigmented, hyperpigmented. These are pictures from the Borden textbook of military medicine of Iranian, most of these are Iranian casualties. Now, this is from Ala. Ala, you want to share with us a little bit? Can you come up here? So they can hear you well. Do we have a microphone, please, for the... you have a microphone, like handheld? Oh, you can just go up to the... go up. Tell us about this guy.
This guy, this is one of several people who came to the ER, but this was on the field.
Yeah.
Okay. Anyway, good morning.
Dr. Ala Mohsen is an emergency physician and Cbrn expert from Iraq. He is currently in Muscat.
Thank you. Do you have the other pictures or just this?
Maybe one more.
We had several cases coming to the ER in Baghdad Teaching Hospital. We have several events of mustard chemical exposure in the war against ISIS from 2014 to 2018. This is one of the people who was decontaminated at the field. And you can see two sides of blisters on his shoulders. He carried an object which is
leaking.
It was contaminated with mustard particles or mustard
liquid
debris. And immediately, this is the second day, I think, because you can see he was, I think he was a civil defense officer.
And remember, it goes through the clothes. It can penetrate through clothes. So he could have been wearing something and still the liquid seeped through the clothes.
We found typical, the first presentation was that they all had respiratory problems, especially the people in, I think Dr. Hussein had more experience in that in Taza, because he went in the field at that time. The first event was in Taza, 2014. And then after that, several attacks appeared in different parts of Iraq, especially in Mosul. Typically, they start with respiratory problems after inhalation of the yellow gas. Sometimes it was with chlorine gas, not just mustard. They used two types of missiles but they present with respiratory problems, mucosal irritation, conjunctivitis, red eyes, secretion, and then second, third day, sometimes to the fourth day, blisters start to appear. That's when actually we diagnosed it was mustard gas after the blisters appeared. Because at the beginning, because several times they used chlorine. It was suspicious of chlorine. But in TASA event, blisters start to form, and then the mustard was diagnosed as the first time. Then several attacks appeared using mustard gas.
There's another picture.
Yeah, these were in the ER in Baghdad Teaching Hospital. They had several attacks. They were admitted in burn unit hospital, and they treated as burns. Only one had respiratory complication from, I think, 14 to 17 patients we had. He developed pneumothorax. I think a blister inside the lung bursted and made a complication of pneumothorax. So, some of them had eye problems, referred to ophthalmology. Dr. Hussein gave a trial of the N-acetylcysteine, but most of them were treated conservatively. The only death was a child, which was from the event of TASA. She was very little, had comorbidities. Child, I think 6 years old. I had the pictures for her. That's the only death from mustard we had.
Good. Thank you.
Thank you.
We checked for bone marrow suppression. If you have significant exposure, the bone marrow is suppressed because remember, sulfur mustard can cause that. And usually it follows the same type of nadir and recovery that you see in radiation injuries. So this is why there's a similarity between sulfur mustard and the radiation exposure. So if you have a blister from a radiation exposure, you may think it's a sulfur mustard exposure, because both of them will cause bone marrow suppression. So be careful with this. But however, the mustard will cause the conjunctivitis and the pulmonary effect, potentially, which you do not see in radiation exposure. Okay? So that's how you're going to differentiate between the two when you take your history or do your physical examination. And these are some pictures of the long-term healings of these mustard. Like I said, lewisite was made for its immediate effect, immediate action, and immediate effect, but was never used. Now, I want to clarify one thing that I may have not said clearly. Sulfur mustard action on the cellular level is immediate, within minutes, but the clinical manifestations are delayed. Remember that, because often if you show up to the ER after sulfur mustard exposure, it's too late to decontaminate. Okay, because already the mustard is entered the body and causes damage. So, and the blisters do not contain mustard. That's another common misconception.